Everyone, I'm so happy to be in Bangladesh again. So actually, I'm a thoracic radiation oncologist. So I'm very happy to be engaged with you with like the head neck specialist to discuss the precision radiation therapy in head neck oncology from my view and to see actually precision radiation therapy is the general idea, and I will bring the China experience to shift how we can to make it in the rest of the world. So I'm from Fudan University, Shanghai Cancer Center, China. So I have been practicing for around 10 years. So my outline today is what we can achieve to be more precise in radiation oncology, including head neck oncology. So I think I put the three outline I'm going to talk. The first is target volume. So what we do is to try to reduce the toxicity without improving recurrence with our maximal ability. And the second is the treatment planning. And what we do is to refining visibility and adoption cross diversity. And the third, which I'm going to share with you, is from the global oncology aspect, which we will see if we can empower precision radiotherapy by artificial intelligence to low and middle income countries. Okay, so this is what I found in Iraq website, the cancer in Bangladesh. So what we can see, esophageal cancer and naropharyngeal and hypopharyngeal cancers are among the top 10 cancers in the map. So as far as I have been visited at the National Cancer Center in Bangladesh yesterday, I can see that head neck cancer are really huge burdens in this country. So what we do in our institution, I think the first important, so I will use NPC as an example in all of my slides as for the head neck oncology. NPC are dominant in China and account for half of the head and neck tumors we are treating. So for the precision radiotherapy in NPC, I think GTV delineation is the first step of all of us who need to do. Currently, multi-modality image fusion is the first step to help precise definite. So this is one of the examples which I took from our clinical pictures. So both like the CT, MR, as well as the endoscopy are critically important in the current days to help to shape it. And this is very more clear is what we can see. Definitely more when we do the CT and MR image fusion, we can improve the precision rate. So this is a very like a vivid picture. And the next step, which can draw more interest of the research and discuss these days, is the CTV optimization, which has been discussed under variations in many different countries and even within countries, the different regions. Our model from our study is based on the local invasion rule. I will just bring one example how we did this. So as far as I don't do head neck tumor directly from my personal clinical background, but as far as this is general rule for everyone, for the lateralization tumor, GTV plus safety may be the CTV margin. So in our case, we use CTV1 and CTV2 based on the recurrence rate, recurrence risk, and then we expand the CTV role. So in our current model, the 10-year the local recurrence-free survival and all survival are quite favorable. And also, based on this rule, we have developed the individualized CT delineation tool in our NPC model in our center. And also, we also did another study about how to individual CT delineation by neck lymphatic drainage region optimization based on the designation of the distance, which was published last year. So in this model, neck laryngeal regional optimization can see that the air cell designation distance less than 3 centimeters can work well in this model. And when we do the trial, we also find another study from the Guangzhou. They have been showed that the reduced volume radiotherapy was non-inferior to conventional volume radiotherapy in local regional relapse-free survival and was associated with lower toxicities and improved survival. So what I want to emphasize to this is what is in our current model of the precision radiotherapy in head and neck tumor. To reduce the target volume is one of the key to reduce toxicity and help to improve the outcome. That will later improve the precision treatment in the clinical practice. So the second phase, I will show how we can in the treatment planning period, how refine versatility and adoption across diversity. So this is an example how we do the AI-driven automated planning with our homemade AI-powered system. This is a framework of the current study of the proposed ATP solution. So we can see this. We use single institutional ATP solution, DO-based dose prediction, and then we recruit site-specific clinical goal list. Each site can provide what they wish. Previously, we have recruited these sites, including the head and neck NPC, as well as general tumors, including breast, lung, cervix, and rectum. So within the data input, our next step is accessibility evaluation. So it's local and external evaluation. So with all the institutions, we got 3 cases with goal list A and 10 cases with goal list B and 10 cases with goal list C. So 250 cases in the total without per patient adjustment we recruit. Then after that phase, we do the AI-driven auto planning and manual planning comparison, and then we produce the DVH matrix to do the clinical assessment in the real-world practice if they can be fit in domestically in China. So next is the applicability improvement, tolerance adjustment of predicted goals raised by each institution. So for the institution level, we will see improved first base rate of accessibility, and also in patient level, we see it's aligned with individual trade-offs. This is the model we do. So in the left picture is what we do with 5 major cancers in our center, including nasopharyngeal carcinoma, lung cancer, breast, cervix, and rectum. And we do the AI-powered planning and manual planning. So the visual comparison of the dose distribution between AI-powered planning and manual plans across 5 diseases. So we can see that it's quite good in the NPC model and rectal model. However, in the lung cancer model, there's still the lack of the plan accessibility. So this result of the blind physician assessment across the different sites and institutions give us the confidence how can we move forward from this to the domestic field to the international field. This is the data we have shown in different size comparison. We see the dot plots of the plan quality comparison between the AI-powered planning and manual planning across 5 diseases. And what we see that currently the model is quite stable in nasopharyngeal tumor in our model. So step by step, we will do the comparison detailed procedures that equalize the time between AI-powered planning and manual planning from planned preparation to final plan production. So this is a representative example of the different strategies for further adjustment for unfavorable ATP plans which our physics can do to fix it. And also a practical methodology for multi-institutional deployment of single-institutional geo models in the proposed AI-powered planning framework, which can show from here from model development, retrospective evaluation, parallel deployment, and prospective application, as this model shows. So next step, I'm going to share with you our think of the empower precision radiotherapy in low and middle countries like Bangladesh, BRI, is a model of nasopharyngeal carcinoma in the global oncology perspective. So this is basically the current framework of what we want to try to establish. So from the beginning, the data was established from the user, from both CT and the retrospective clinical data from our center. So all the model was trained in Fudan University Shanghai Center with the patient data recruited in our center and verified with other institutions in China. And then we do the prediction with both dose distribution and Eclipse API. And we, Fudan University, will provide the script. And then we will deliver the plan model for evaluation in different sites to help to see if this model can help low and middle income country to improve the radiotherapy accessibility in the precision level. So the specific aim of the study is to develop and deploy Eclipse native ATP pipeline that integrates steroid dose prediction with clinical goal-guided inverse optimization using SAP and Eclipse phaeton optimizer with agro SAA starting from a lead center deal model. And M2 is quantify clinical accessibility and domestic non-inferiority of ATP with manual planning for across diverse low and middle income centers, and also to evaluate the implementation outcomes, including both planning time, first pass delivery, patient-centered QA, user workload trust, and center-level generability, and produce site-tailored goal list and operating procedures for the sustainable operation. And this design will be a multi-center prospective paired non-inferiority evaluation with initial retrospective run-in plan pairing on historical MPC cases to finalize site-specific goal tolerance and SOPs. So the sites can be coordination lead centers with probably more than 4 low and middle income countries in the region to capture the heterogeneity in the imaging or beam geometry, fractalization, and evaluation protocols. This product result can support generalizability across such variations. And the population included must be adults with pathologically confirmed MPC planned for phaeton MRT. And this unit of analysis will be per patient paired plan, both Eclipse AI powered plan versus clinical manual plan with blind physician review. The primary outcome will be the clinical acceptability rate that is on the site level majority of 3 blind physicians per case, clinical usable or not, and also domestic non-inferiority on pre-specific DVH endpoints, PDV coverage, conformability, heterogeneity, instance 0, OAR, Dmax, and etc. And the secondary outcome is more focused on implementation, including planning time end-to-end, including essential manual steps. Target is less reduction versus its manual, consistent with previous evidence. And user workload, which we think is quite important because in low and middle income countries, there's a huge lack of workforce in the medical professionals, especially the medical physics. So the generalizability, accessibility, and non-inferiority across centers versus tolerance settings that are being practiced, and also the number of user interactions. And also, of course, this has to be planned to review each case years to plans, manual versus AI blinded by source. 3 expert physicians per site score accessibility, performance, and generation methods gets comments captured for quantitative analysis. And we expect to plan to 10 nasopharyngeal cases per site and a total of more than 60 to ensure the stable switch with the center random effects. So that's basically what I wanted to introduce, and we hope like this AI tool can help like the resources limited area in like low and middle income country will have the more opportunity to the precision radiation therapy, including head neck oncology. So thank you.